Okay, so let's talk about a few peripheral neuropathies. Okay, and the first one we're going to talk about is Bell's palsy, which is a dysfunction, a temporary dysfunction of the seventh cranial nerve, typically on one side of the body. Okay, so the seventh cranial nerve exits the pons in the brainstem and has this long route that actually goes through the middle ear, and then it comes out close to where the outer ear is, and then it supplies the nerve, the motor nerve to that side of the face. Okay, uh, so patients often come in thinking they've had a stroke. They're unable to raise their eyebrow. They're unable to raise their forehead on that side. They can't smile on the affected side, and their lip often droops on that side. So patients often come in worried that they've had a stroke, okay? When in actual fact, it's a nerve palsy, okay? It's the facial nerve that is temporarily not working. And for the most part, we don't have any idea what's caused it. We think because the facial nerve has a very long route, sometimes it can become kinked or inflamed. Uh, we think some patients can develop this from a herpes infection, and we've seen patients with Lyme disease come in with um, Bell's palsy. Okay. Okay, so what are the symptoms that they commonly get? So I mentioned the motor weakness of the forehead, inability to actually close the eye. All right, so the eyelids are unable to contract and close, so their eye stays open. Their cheek muscles are weak, so they can't smile. They have a droopy lip on that side. Often they're drooling on that side. They have abnormal taste on that side because the anterior two-thirds of the tongue is innervated by the cranial nerve 7. And because this cranial nerve goes through the ear on the affected side, um, and innervates and controls those three tiny bones in the ear, because that's affected, they complain that sounds are louder on the affected side. Okay, so they can complain that all the sounds are just too loud on the affected side. Their muscles of the face are weak on that side. Their taste is different, and they can't close their eye. Okay, and remember, it's unilateral. It's only on one side, right? Okay, so it's totally understandable when someone comes in thinking they've had a stroke, okay, because of all these symptoms that they have. Now, the vast majority of patients with Bell's palsy will have a return to normal function, typically in weeks to months. Okay, now a small percentage, probably around 5 to 10%, uh, won't have a complete return to normal function of their facial muscles. Okay, and they'll be left with some degree of weakness. And it's impossible to predict at the beginning who's going to be left with some facial weakness. So, so how do we treat Bell's palsy? Well, the first thing to remember is they can't close their eye. So the cornea is going to dry out. So they typically need lubricant drops to put in their eye throughout the day, very frequently, because their eye isn't being lubricated by the blinking, right? They're not able to blink. And often at night, we'll put in some lubricant drops or some lubricant ointment and tape their eye shut so that the cornea doesn't dry out overnight. Okay, so that's the treatment for the eye. The treatment for the actual cranial nerve 7 palsy, because we think some of these are caused by the herpes virus, we'll actually use an antiviral, such as acyclovir, on the chance that the herpes virus is involved. Okay. The other treatment that we do is we put them on a short course, typically 5 to 7 days, of an oral corticosteroid, such as prednisone, to reduce the inflammation. Okay, so they get an antiviral for a week, they get a corticosteroid, such as prednisone, for a week, and they have to lubricate their eye frequently to avoid corneal ulcers from forming. So now the big question becomes, how do we distinguish between a stroke and Bell's palsy? Well, if you remember with Bell's palsy that we've just spoken about, it causes complete paralysis of the entire affected side. So your forehead doesn't move at all. Okay, so you can't frown, you can't close your eye, you can't smile, and you might be drooling a bit on the affected side. Okay, a lot of those sound like stroke, except for one. So we know that the nerves from the left side of the brain cross over to the right side of the body, and the nerves on the right side of the brain cross over to the left side of the body. Okay. It just so happens that some fibers don't completely cross over, meaning that if this was a stroke, okay, so you have weakness to the cheeks, you have a droopy lip, you might have some drooling, but with a stroke, you would still be able to raise your eyebrow and to have some forehead frowning. Okay? And why is that? Well, because the forehead is partially innervated, so the nerves to the forehead have nerves that come from the same side of the brain. Okay, so if this was a stroke, you should still be able to raise your forehead muscles. Okay, you should still be able to have some forehead frowning. Okay, whereas with Bell's palsy, it's completely paralyzed the facial nerve. So you can't, your forehead, your cheek, your lip on that side doesn't work. Okay, so let's just say, like in this image, the right side of the face isn't working. Let's go through a stroke. Let's see if this is a stroke. Okay, so if it was a left cerebral stroke, I would expect that, sure, there's droopiness of the lip, there's inability to use the right cheek muscles, but I should still be able to raise my forehead muscles and have some forehead frowning ability, okay? Because some of the nerves that supply the right forehead come from the right brain, the right hemisphere. So that's how we distinguish between Bell's palsy and an acute stroke in this setting. Okay, we're looking at the forehead to see if it's completely paralyzed. Well, that's Bell's palsy. If they can still move the forehead muscles and contract them, we're much more concerned about a stroke.
Okay, so I've mentioned herpes zoster before, which is also called shingles. And it's called shingles just because of the blistering rash that comes out. And, some people felt it had the appearance of shingles at one point. The real term is herpes zoster. So this is a peripheral neuropathy of one dermatome, of one sensory nerve, okay? And it's caused by the chickenpox virus. So if you had chickenpox as a child, then you have the potential to get herpes zoster at any point in your life, because the chickenpox virus lives in your spinal cord permanently. So you could get one episode of herpes zoster, or you could get many episodes of herpes zoster through your life. And it doesn't always have to be in the same spot. So it's a painful, blistering skin rash along one nerve root, unilateral, one-sided. If you see a rash on both sides of someone's back or chest, it can't be herpes zoster, because the virus that gets activated in the spinal cord only goes down one side, first of all, at a time, and one nerve root. Okay, and there's often pain and tingling before this rash comes out, which can be sometimes very hard. So if someone comes in with chest pain and we can't find anything, and in the end it's going to be herpes zoster, but there's no rash yet. So, we can look and look and look, and finally, 2 days later, a rash comes out, and we realize, oh, okay, it was herpes zoster. And the rash usually heals in 2 to 4 weeks. And people often ask, is it infectious? It's only infectious when it's weeping. So if the blisters are weeping, well, there's viral particles within the weeping fluid. So we'll often tell people to cover it if it's weeping. Weeping, I mean like leaking fluid. So what are the risk factors? Well, just getting older, our immune system gradually diminishes. So it's more of a chance that as you get older, you can have activation of the varicella virus that's been in your spinal cord for years. Something that reduces the immune system. So chemotherapy agents, prednisone itself can actually, will reduce your immune system and predispose you to an outbreak of herpes zoster. So anything that lowers the immune system. An acute illness. So why would an acute illness, like a severe illness like a pneumonia, activate herpes zoster? Well, you're under stress. So the body's under stress, and when that happens, you can have an outbreak of herpes zoster. And some people notice that the only thing that's changed in their lives is some kind of acute stress, and then they developed herpes zoster. So chemotherapy we mentioned, since it suppresses the immune system. But any age can get it. You can be a child and get herpes zoster, and you can be an old person and get herpes zoster, or anywhere in between. But it's more common in older people. So it's caused by a varicella zoster virus. So VZV. I know you call Z or Z. We just pronounce it differently. Following chickenpox as a child, and then it stays in what's called your dorsal root ganglion forever. Okay, so it lives in the spinal cord once you've had chickenpox. It is not a herpes virus. Okay. So the rash is really the inflamed nerve under the skin. It can be exquisitely painful. And if you go back and look at neuropathic pain, shooting, sharp, dagger-like pain that can continue even after the rash has resolved in 2 to 4 weeks. And that is one of the problems with herpes zoster, is that you can be left with a neuropathy called post-herpetic neuralgia. So the and it's deceiving, right? It's not even a herpes virus, and we're calling it post-herpetic neuralgia. Anyways, the neuralgia, so the virus activated this sensory nerve, and the virus is now gone. The skin is now healed, but you're left with this really irritated, activated nerve inside that continues to fire signals once the acute pain or the acute inflammation has settled, which we really try to avoid by treating herpes zoster with antiviral medications, but they need to be given within 3 days, 72 hours. They're not effective if started 3 days after the rash comes out. Okay, so if someone comes in and says, I've had this rash for 5 days, we usually tell them that the antiviral medication is not going to be effective. So within 3 days, we use antiviral medications like acyclovir. Okay, and this has been shown to reduce the chances of getting post-herpetic neuralgia, which is the severe, ongoing, chronic neuropathy from the initial infection and inflammation, and this can last for months to years. And here is another place that we sometimes have to use nerve modulators, gabapentin, pregabalin, tricyclic antidepressants that can modulate the nerves to try and treat this pain. Okay, and here's a rash. Here's the rash of herpes zoster. So it's usually in one dermatome, one sensory dermatome. So if you want to go back to the dermatome diagram we had not too long ago, it'll be in one of those sensory dermatomes. It can be on the face, which is more serious because some of the dermatomes are around the eye, and herpes zoster can go onto the eye if it's the nerve root that surrounds the eye. So that can be very serious and damage the cornea. So you can have significant eye injury or corneal injury because the virus got onto the cornea from having had the rash around the eye. This is along the left chest here, so you can see the blisters and the inflammation, which will gradually settle down over 2 to 4 weeks, especially if we use antiviral medications within the first 3 days of getting the rash. And then hopefully the patient doesn't develop post-herpetic neuralgia that lasts for years, potentially years, sometimes months.